I'm just going to give it a few more seconds while more people join, but in the interim, welcome everybody who's joined so far. Okay, the numbers seem to be slowing down, so I think we'll kick off. Good afternoon, everybody. Thank you so much for joining us this afternoon. My name is Victoria Thomas. I'm the Head of Public Involvement here at NICE, and today's webinar is looking at how we can help health professionals put shared decision-making into practice. And we've got a fantastic lineup of speakers, but I want to do just a bit of admin before we get going. So the webinar is being recorded and will be made available on NICE's YouTube channel in a few days' time. So we'll be able to let you know when that goes live if you want to revisit anything or share it with your colleagues. We have enabled closed captioning. So if you want to take advantage of that, you can just press the CC button at the bottom of your screen. That will give you a kind of running subtitling option throughout the presentations, which will be helpful for some people. We're going to have one Q&A session at the end of the webinar rather than having questions after each session. The chat is turned off for the participants, so please use the Q&A function to put any questions you want to the panel. You can put your questions in at any point, but we'll only look at them towards the end. Any questions that we don't get to in terms of answering them live today, we'll collate and do a thematic response to. Following the webinar, you'll also be prompted to complete a short survey so that we can do any kind of quality improvement we need to as a consequence of today's webinar. The aim, as I've said, is to help people make shared decision-making a reality in practice. By the end of the session, we hope that you as participants will be able to explain what shared decision-making is and what it's not, evaluate the potential benefits to you from greater use of shared decision-making in your professional practice, assess the possible barriers and enablers to greater use of shared decision-making, and to be able to formulate a plan about how you can develop your professional practice to incorporate greater use of shared decision-making. We're going to kick off, as I think we always should, with the patient perspective, and I'm delighted that Sian Phipps, who was one of the lay members of the NICE guideline committee that produced NICE's guideline on shared decision-making, will open for us in a minute. She'll be followed by Alf Collins, who will provide us with the policy context from NHS England and NHS Improvement. Ashok Handa, who is a consultant vascular surgeon based in Oxford, will talk about why SDM matters as a healthcare professional. My colleague Andy Hutchinson will give you a brief introduction to the guideline itself and some useful tools about how you might put it into practice. And then Julian Treadwell, who is a GP and a doctoral research fellow with the NHR, will talk about shared decision-making in general practice, and then we'll move into the Q&A. So if I may, Sian, I'll hand over to you to tell us about why it matters from a patient and lay perspective.
Thank you, Victoria. Prynhawn da, everybody. Good afternoon. I feel very privileged to be able to speak to you today about shared decision making, although a little nervous that there are so many of you interested in the subject. I've been asked to give a patient perspective of shared decision making. So to put that into context, I'll start by saying that 50% of patients want more involvement in their treatment and care. And I'd like to cover three main areas, if I may. First, very briefly, my patient story and my motivation for being involved in shared decision making. Secondly, what I think shared decision making means for patients. And thirdly, just some thoughts on how perhaps you can make a difference for the patients that you serve. So first of all, my story is that I'm an oncology patient. Before being diagnosed, I think my experience was the exact opposite of shared decision making. My options weren't really fully explained to me. I don't think I fully understood the implications of each of those options. I ended up receiving a course of treatment which turned out to be very wrong for me. And it culminated in my having to have emergency surgery, in which case all decisions were completely taken out of my hands. So, and in the end, I ended up with leiomyosarcoma. So it was a rather horrible experience, but it explains my motivation then for being involved with NICE when they wanted lay members to be part of a committee for developing a guideline. And I was one of 3 lay members on that committee. So what do I think shared decision making means to patients? Well, I think it's very much a process, it's not an event. It starts way before patients step foot into a medical centre, so it's before a clinical appointment. It continues throughout the appointment and after each consultation. It's about changing cultures and behaviours, both in terms of professionals and patients. It's about empowering us as patients to feel that we have ownership over our own treatment and care. It's about creating a more equal partnership between professionals and patients based on confidence and trust, and each of us is expert in our own ways. It's an ongoing dialogue, and it's about making people feel better about the whole process and therefore improving outcomes. In Wales, we've got, because I can't say shared decision making very well, we call it making choices together, which I think is what it's all about. And I do remember my oncologist telling me that the best thing that ever happened to her, well, actually it was pretty horrible because she had a really bad break of her leg, but she said for the very first time in her life, she was able to be a patient and to see things from a patient's point of view. And that affected then the approach she took in her work. So what does shared decision making entail? Well, it happens, I think I mentioned before, it happens upstream. Before patients even have their appointment, it's about providing them with solid, reliable information, leaflets, videos, phone calls, ensuring that patients really know what to expect when they then have a face-to-face appointment. It's about establishing a real rapport between patients and professionals, so getting to know each other, understanding what's important to someone as an individual. No patient is alike, knowing what their values are, what their priorities are, affects then their preferences. So it's very much about asking a patient, well, what matters to you, rather than what's the matter with you. I think only when those foundations are in place is it then about talking about options and including in those list of options that there's a do nothing option. It's then about explaining and understanding each option, the pros and the cons, in a very frank and honest way so that people understand, and seeking confirmation, I think, that people have understood what's been discussed before then taking a decision together about treatment and care. And that's very personalised and tailored to a person's preferences, which are obviously based on the understanding that you have of their priorities and their values. But it's also about changing your mind at any point and feeling supported and reaching a mutual decision about changing your mind. I just mentioned something that the NHS in Wales has produced. It's a little leaflet, I don't know if you can see it there, saying ask 3 questions, and it was left in hospitals and patient surgeries to encourage patients to say, well, what are my options? what are the benefits and the risks, and what can I do to help myself. So it's really very much about giving leadership to your patients. And finally, then, what perhaps could you take away from today that would help to affect change? Firstly, just question your assumptions. If you think you already do shared decision making, maybe just have a look at the NICE guideline just to check that you do. Make shared decision making the norm, not the exception. Create the climate for shared decision making, so that leadership at the highest level, be it a board member, a director, but also very much there's an individual responsibility just to change perhaps the conversation that you have with patients. And David Gilbert, we on the committee, we did look at the way that they had a patient director, a patient forum, and patient champions. It was that like triumvirate, which gave a real impetus to taking forward that culture and that behaviour. Encourage your patients to ask 3 questions. And finally, in training yourself and your staff, include patients in formulating and delivering those training sessions. So in summary, I'd just like to say that I think shared decision making has the potential to transform people's experience of their health and their social care. It signals a new equal partnership between professionals, patients, their carers and their families. It creates change, and it puts people firmly at the heart of our healthcare settings and systems. And lastly, thank you very much for listening to my patient's story, and thank you as well from one patient to all the amazing work that you do every single day. So thank you very much.
Thank you, Sian. Thank you so much. It's really fantastic to hear that personal perspective, but also the way you've been able to take your personal perspective and apply it to kind of a broader set of principles. And that's why you were exactly the right kind of person to sit on our committee. And we're hugely grateful to you for all the work that you have done. And thank you again so much for sharing it. And I'm hoping that through exercises like today, it won't take clinicians becoming poorly themselves for them to consider these issues. Thank you very much. Unfortunately, Alf Collins from NHS England and NHS Improvement hasn't arrived. So I think that what we'll do is we'll move straight on to Ashok, if that's okay with you, Ashok. And if Alf joins us, we can come back to his presentation. If not, he gave us a very similar presentation to the one he was planning to give today at the session we held last week, which will be available on NICE's YouTube channel, so we can always refer people to that if need be. Ashok, would that be okay if we go straight on to your presentation?
Yeah, absolutely. Yeah. So thank you very much for inviting me, and you've already kindly introduced me. So why is shared decision making important to healthcare professionals? Next slide, please. Well, this segues from what we just heard Sian talk about, that assumptions are a major cause of misunderstanding. And of course, if I think I know best, doctor knows best, or the nurse knows best, etc., it's often based on our clinical expertise, but also on this assumption that we know what the patient wants. Next slide, please. And of course, if you play Russian roulette, then you will be right 5 times out of 6. So that's the thing that we have to avoid. Next slide, please. So we have quite a lot in our clinical toolkit to help us with decision making. Obviously, top of that list will be evidence. That's why it's a nice webinar where all of that is looked at very carefully on our behalves by an expert team, and the methodology is really used around the world. When we go to the NICE conference each year, people come from all over the world, and I say, why are you here? I say, well, you've done all the hard work. Why we don't need to repeat it. But we also have supporting us ethics, law, decision analysis, decision aids, health economics, etc. So let's go through these. Next slide, please. Well, David Sackett's original definition of evidence-based medicine was the integration of best evidence with clinical experience and taking into account patients' values. That was his original definition. And what I think has happened is that we've had a long period, 25 years, of working out how to get the best evidence, how to use clinical experience. And I think sometimes we've forgotten the patient values within that. Next slide, please. And on the ethics side, well, you know, we have really good guidance from the GMC. We have a world-class regulator, and they talk about consent, and they talk primarily about patients and doctors making decisions together. But if you ask patients, they don't feel that we're making decisions together, and we really just heard a really good example of that. And for example, many MDTs do not have the patient's voice within that decision-making process. Next slide, please. But of course, now, since 2015, we also have legal support for this. And of course, the Montgomery judgment really took evidence from things like the GMC, like the Nursing Midwifery Council, like the Professional Standards Authority. And they really ruled to say that values and evidence have to come together as part of the basis of shared decision-making. And as a prelude to the NICE guidance, it really framed it in a beautiful way, I think. And if you haven't read it, please do look at just the executive summary. And it tells you exactly what Montgomery says is shared decision-making and what isn't good shared decision-making. Next slide, please. So I want to talk about a patient. I want to talk about Mrs. Jones, a real patient from a practice in Oxford, a lady in her 70s, who had been to see her GP about 4 times, progressive symptoms of painful knee with arthritis, and she got referred to one of the orthopedic surgeons at Nuffield Orthopedic Centre. And she went and saw a surgeon who, you know, good doctor, good history, examination, investigations, discussed all the options, and discussed the option of having a prosthetic knee joint, I think it was a unicondylar, and discuss the risks and benefits. And at the end of that consultation, Mrs. Jones, at the door, hand on the door, opening the door slightly, saying, well, thank goodness for that, doctor. My GP said you'd probably fob me off, but I'm glad you're going to get this done because I can finally get on with my gardening. And he had alarm bells ringing. He said, no, hang on, shut the door, come back and sit down, tell me a bit more about it. And it turns out that Mrs. Jones was a very keen gardener. She's a widow, and you know, 7 days a week, 365 days a year, rain, hail, sunshine, she was in her garden. That's what she lived for and loved. And she, you know, had her open garden every year in the summer season, and won a few competitions doing that. And then the surgeon said, well, we now have a problem because I can get rid of the pain in your knee. What I can't guarantee is that you'll be able to bend at 90 degrees so that you'll be able to kneel down and garden. And after a discussion, Mr. Jones said, well, if that's the case, I don't want to have it because the gardening is more important to me. And so they agreed that she would have a combination of physiotherapy and the non-steroidals as required. 3 years later, actually now 4 years later, still no knee replacement. She's happy, and somebody else can have that knee replacement. Next slide, please. And so listening to what mattered to Mrs. Jones, plus using the best evidence, meant that she had an improved clinical outcome. She was much happier, and we saved money for the NHS as a byproduct. Next slide, please. So how has shared decision-making changed my practice? Well, for a long time, teaching both students and trainees, I used to say, well, look, there are only 3 types of decision making. Decision 1 is where the evidence is overwhelmingly saying that a particular course of action has very low risk, huge benefits for the patient, and I can recommend that treatment. An example from vascular surgery is someone with symptomatic carotid stenosis over 70%. You can say, look, you know, we're going to bring your stroke rate down from 18% in the next year down to less than 3%. And in fact, in some people's practice, nearly 0%. And you can recommend it. The patient can still say no, in which case you might say, well, interesting, you should say that. Why do you say that? What's important to you? And you might have a dialogue with them, and they may still choose not to have it. The other end is a second decision type where the patient is seeking a particular course of action or a treatment or a diagnostic where you know that the risks are very high, the benefits virtually none, and you can say to patients, I'm not prepared to provide you with that intervention or course of action. Now, my practice has always been, if you can tell if a patient's unhappy, you can say, I can see you're unhappy with that. Would you like a second opinion from one of my colleagues? Actually, as it happened in Oxford at that time, I only had 4 colleagues. I said, would you like to see one of my 4 colleagues? And the patient said to me about 5 years, well, you would say that, wouldn't you? And I said, well, that's interesting, Taylor. Why do you say that? I said, well, they're all your mates and friends, aren't they? They'll all say the same as you. And I said, oh, I understand where you're coming from. Actually, they are my professional colleagues. I see how you might feel that. One of the 4 is my friend. That tells you about my relationship with some of my colleagues, maybe. In any case, I think, in my experience, if you volunteer unsolicited a second opinion, the vast majority, over 95%, never want that second opinion because you've been open and transparent and offered it without being asked for it. But then there's a third type of decision where there might be 2, 3, 4 different courses of action, each with a reasonable evidence base. And you can say you can have treatment A, B, C, D, E. And my practice had always been, here's the risks, here are the benefits, you choose, and whichever choice you make, I will support you. An example is from, I don't know, varicose veins, where you might have no treatment, stockings, injections, sclerotherapy, endovenous laser treatment, or surgery. And what happens next is that at around 80 to 85% of people say, what would you do, doctor? And before I started to think about shared decision-making, I would say, well, in my experience, you should have surgery, someone else should have something else. And that was based on the first 2 bits of what David Sackett said, best evidence and clinical experience. But I wasn't taking into account patients' values. What I do now, next slide, please, is to say, well, interesting, you should say that. Now, why don't you tell me the sorts of things that are important to you? And then together, we can choose which of these choices is going to suit you and your circumstances the best. And it does take a little bit longer to have these conversations. And what I found in secondary care is if it's a very serious condition, the discussions don't take very long. It's only in the more trivial that the discussions take longer because there are more options for patients. Next slide, please. So what we're saying here is that take all the best evidence, put into practice the values of what's important to the patient, and together you'll have good shared decision-making. Next slide, please. So I just want to end there by summarizing is that, so the question I was asked was, why should we as health professionals be involved in shared decision-making? And the answer is, 1, it's the right thing to do, both morally and ethically. Secondly, the law says we should do this. Think about Montgomery. The third thing is, it's the smart thing to do for the health economics. Remember Mrs. Jones, unnecessary operation prevented. And also we know that 1/3 of all prescriptions are never cashed in, but a further 1/3 only used not as directed. So there's a whole lot of waste going on in the system. And then it improves patients' experience because they feel involved, as you heard from Sian, they feel engaged, they feel listened to, and there's better concordance with the prescribed treatment if you have that level of engagement. And the final thing is really important, is that shared decision-making means that the patient also shares responsibility for the outcome. And if you think about all the money we're wasting in litigation and NHS resolution, that's where the real savings are. So it's better medicine equals cheaper for the healthcare. Thank you.
Brilliant. Thank you so much, Ashok, and thank you for really marrying the concepts of evidence-based practice with the patient experience and reminding us that actually it was always there in David Sackett's kind of description of evidence-based medicine. It was there when Richard Dole did his, analysis of smoking causing cancer. Like there's always the kind of having to get the 3 parts working together, and it's really, really salutary to be reminded of that. And it's also really good for you to be describing the kind of the benefits that you see over and above the kind of moral and ethical side of things. So thank you so much. A reminder to participants that if you have any questions for Ashok or any of our panelists, please do put them in the Q&A and we can get to them at the end. I'm now delighted to introduce Alf Collins, the Clinical Director for Personalised Care at NHS England and NHS Improvement. I'm sorry we started without you, Alf, but we're delighted that you're here now. So I'm going to hand over to you, if I may. Thank you so much.
Victoria, thank you. Thanks very much. Afternoon, everybody. I don't know what the weather's like where you are, but it's still really warm and sunny in London. I think it's about to turn, isn't it? It's going to move back from spring to winter over the next day or two. Yeah, I'm Alf Collins. I'm Clinical Director for Personalised Care, and one of my policy responsibilities and my major interest is shared decision making. So I'm just going to share with you over 3 or 4 minutes where we are going in terms of national policy in England. Next slide, please. So as part of our long-term plan commitments, we've got a commitment to what we call universal personalised care. And I'm not going to talk through this slide in enormous detail, but there are 6 components, we believe, to universal personalised care. It's really symbolically the coming together of person-centred care and personalisation. So it brings together the concepts within person-centred care of shared decision-making, personalised care and support planning, support for self-management and social prescribing, and from personalisation, the concepts of personalised care and support planning, choice and personal health budget. So 6 components in all. And the bottom component, what we believe the whole population should be experiencing every time they're in a conversation with their health or care professional, is a shared decision-making conversation. So next slide, please. I worked for 10 years in the Health Foundation and worked closely with the MAGIC team in the Health Foundation. If you don't know about the MAGIC program, do look it up. What we found in that program is that you've got to do 4 chunks of work in order to implement shared decision making. One was to make sure that the services that you have are indeed commissioned. So it's all very well, working with someone with knee pain in primary care and thinking about the various options. If you don't have access to local walking groups via a social prescribing link worker, then you won't have a conversation about local walking groups. So there is something about being clear about what's on your menu of options in your local system and that you indeed do commission it. We need to make sure that the public are prepared. So that's ask 3 questions, having decision support tools beforehand, etc., etc. We've got to make sure the system itself supports the conversations, the process of shared decision making. So that may well mean having decision support tools in the workflows instantly available at the point of care. We need to make sure those decision support tools are health literate. We also need to do is make sure that our teams are trained in motivational interviewing and risk communication. So 4 chunks of work, and I know we're going to be talking much more about implementation across this webinar. Next slide, please. And this is my last slide coming up. We've got a little arrow. There it is. Okay, fantastic. Policy is an interesting place to work. Essentially, what you do is seize opportunities and kind of pull the opportunities together. So if there's 2 or 3 opportunities, you make sure they all work in the same space. Clearly, you'll all know that one of the big challenges, stroke opportunities at the moment, is the elective care programme. So we're very much focusing on the elective care programme in our work in NHS England at the moment, including specifically the very high volume specialities like MSK, eyes, and also the evidence-based intervention programme, a programme of work which is looking at ensuring that patients who are considering a low value procedure indeed do know the benefits and harms of the various options available, including the procedure itself. So a big focus on elective care, and we've always worked with NICE, we're going to continue to work with NICE. We're also working with the Winton Centre for Risk Communication in Cambridge to produce some simple, straightforward, evidence-based decision support tools, patient decision aids, to be used in consultations within the elective care programme. We're also doing a lot of work in maternity. Many of you will know that the next Ockenden report is due out in 2 days' time, and the Ockenden review is about making sure that maternity services are personalised and safe. So we're working hard to promote shared decision making in the maternity programme, and again, working with the Winton Centre to develop some decision support tools there. Thirdly and lastly, another big policy priority for us is the National Overprescribing Review. We know that there's a heap of medicines that we perhaps overprescribe, including dependence-forming medicines like the gabapentinoids, opioids and medications for people with mild to moderate anxiety and depression. So we're working again to produce some simple decision support tools there, working also with CPPE, the Centre for Pharmacy Postgraduate Education, there I got it right this time, and also the Personalised Care Institute to make sure that we've got training available for teams across those three big national priorities. So I just wanted to share with you where we are, where we're going in England. That's just a few minutes from me, and I'm sorry I was late. Victoria, back to you.
Not at all. Thank you so much, Alf. Are you able to stay for the rest of the session?
I wish I were. I've
Okay.
just got to dip off. I'm so sorry.
Okay, no, that's absolutely fine. Thank you so much for coming and so much for sharing. And as before, if there are queries that relate specifically to the points that you've raised, can we bring these back to you at a future date? I think it's really interesting, just before you go, that in the two presentations we've already had this morning, people have talked, both Sian and Ashok have talked about not making assumptions about what it is people want. And actually those three key policy areas around elective care and maternity and prescribing, that issue about making assumptions about what it is people want, that's very front and center, isn't it? So it's really, really important that shared decision making becomes part of that agenda. Would you agree?
Absolutely, yeah. Patient preferences really do matter. And those of you who haven't read Patient Preferences Matter from the King's Fund in 2011, do look it up. Back to you, Victoria.
Thank you so much. And I thoroughly agree. It's a very, very good read. Thank you so much, Alf, for joining us. I'm going to pass over to my colleague, Andy Hutchinson, who's going to take us through NICE's guideline, NG 197, on shared decision making, and give us some reflections on what this might look like in practice as well. So thank you, Andy, over to you. You're on mute.
It works better if I unmute myself, doesn't it? Thanks very much, Victoria. So yeah, I'm Andy. I'm a pharmacist from the medicines team here at NICE. And before joining NICE, I worked in, well, PCTs, there we are, showing my age, but also in hospital practice as well. So the guideline really covers how to make shared decision-making part of everyday care. That's the point. Some of us are old enough to remember when clinical governance was a thing, and there were chapters in documents and plans and things around entitled clinical governance and how we were going to bring clinical governance into that new service or whatever it was. And you don't see that anymore because clinical governance just runs through everything, and that's really the aim for shared decision making, that it will be the sea in which we swim. So the guideline has some recommendations in 4 kind of chunks about the sort of organizational level stuff, the supportive systems that Alf was just talking about, and that also includes some of the things that Sian was mentioning earlier around preparing people and getting people ready to be involved in shared decision making, patients and service users. So that's the prepared patients, stuff around shared decision making into practice, and real practical stuff which I'll spend most of the time talking about here. And then there's also a little bit about patient decision aids and communicating risks, benefits and consequences. It's not a long read, but I really would commend NG 197 to you as part of your CPD. It's one of the sort of foundation guidelines, along with the patient experience guideline, CG 138. There's NG 56 on multimorbidity, which is very closely aligned to this. And there's also NG 5 on medicines optimization, and that's just to prove how sad I really am that I can actually remember the guideline numbers. But before going any further, I just want to put a note around NICE guidelines generally. 2 things really. First of all, not everybody knows this, but the words we use in the guidelines, in the recs, are important. When we say offer or something like that, then there is pretty clear evidence of benefit, or a balance in favor of the whatever we're recommending. When we say consider, then it's a bit more nuanced. But in both cases, it's really important that patients are involved in making informed decisions about their care. Yes, of course, we really want you to take NICE guidance into account when you're making decisions with and for patients. It's really, that's we spend a lot of time producing them to a high standard, but, and it says this on every guideline landing page, although it's a bit like the terms and conditions that everyone says, yeah, I've read, and then clicks on. It says it's not mandatory to apply the recommendations. You have to take the person's individual needs, preferences, circumstances, values, aims, goals, bring the person into account. It's really important. So as our former chair, David Haslam, used to say, these are guidelines, not tram lines. So going on to the guideline, embedding shared decision making, it talks about high level leadership. And as Sean mentioned, it talks about having board level leadership for that, but also it talks about having healthcare professionals as shared decision making champions, and thinking our audience for this webinar is particularly the doers, the people who are actually looking after patients, then maybe you could be one of those champions. That would be great. Also talks about involving service users and service users patients as you plan your how you're going to bring shared decision making into your organization. It does say you need a plan, and it also talks about how to monitor and evaluate your progress. If we just move on, please. It talks about better sharing of information so that the person doesn't have to repeat the same information, and also there's a bit more seamless care. And there's quite a lot about supporting healthcare professionals' skills and competencies, and also promoting shared decision making, as I said, to patients or service users. There's, as I said, there's quite a bit of detail about how to put shared decision making into practice. Some real practically useful stuff there. And that includes before discussion, and discussion is just the word the guideline used to cover every kind of consultation, interaction, conversation, everything where you're making a decision with the patient or service user. During the discussion, which I'll speak more about in a moment, and then after or between discussions. And I'd point out that one of the recommendations is to write clinic letters, say from a hospital specialist to a GP. Don't actually address it to the GP full of sort of technical medical language, but actually address it to the person. CC the GP. And the Academy of Medical Royal Colleges has recommended this for some time, and there's some great resources on their website, including some sort of 2 ways to write the same letter kind of thing, which is well worth looking at. So moving on, the guideline suggests the 3-talk model as a practical way of doing shared decision making. 3 steps: introducing choice, describing options, and then coming to a decision together. So if I were the healthcare professional talking to Victoria, I'd say, okay, well, Victoria, you have XYZ condition, as you know, and we'd spend a little time making sure that you understood that. And I'd say, so there are a couple of things that we could do now, and it's important that we come to a decision together that you're happy with, it, that takes account of what's important to you, or words along those lines. That's the choice talk, and the language we put there is really important, because if I just said, okay, Victoria, what would you like to do? Victoria's likely to say, well, I don't know. What do you think, doctor or pharmacist or whatever? But this is about, as Sean said right at the beginning, shifting the perspective from what's the matter with you to what matters to you. So I'd say that there was these choices, and then in the option talk phase, I'd explain what they were, with depth of information as appropriate to whatever Victoria wanted. And then we move to a decision talk, and it might be sort of, so what are you going for? And Victoria might say, well, actually, I want to do this. Or I might say, well, reflecting back on from what you've told me is important, it sounds like such and such might be the best option. What do you think? How do you feel about that? Anyway, that's what we do. So that's one part of the techniques that we recommend. The next is chunk and check and teach back. I wouldn't just splurge all that information to Victoria in one go. I try and break it down into little manageable chunks, and after each chunk I want to check back that I've communicated that effectively, and that's teach back. So it's not just saying, do you understand? Because Victoria's likely to say yes, even if she didn't, because she doesn't want to look a fool. But if I say, so Victoria, can I just check that I've communicated this properly? Can I just check that I've got that clear for you? Could you explain back to me what your understanding is? then I can check that understanding, and also actually putting it into words helps Victoria formulate it and sort of make sense of it. Thanks very much. Moving on. So as I say, there's something about patient decision aids, and really the point is that PDAs can be a really valuable part of the toolkit, but they're certainly not essential, nor is it that simply having a PDA means that shared decision making is done. They're part of that toolkit. And there's also some guidance about the best way to communicate risks and benefits in a balanced, easier to understand way. So I commend those to you. Looking at practical tools, there's the NHS England website has some great resources linked from it. There's a summary guide and implementation checklist, which if you have a kind of responsibility, a sort of a strategic responsibility, is well worth looking at. And a couple of measures there, Collaborate and SDMQ9. Collaborate is a simple 3-item questionnaire that you can use with patients to sort of explore how well they feel they were involved in the decision making. And there's an MSK service in the Northwest, I know, having spoken directly to the people there, that use that routinely. SDMQ9 and SDMQ-Doc, they go into a bit more detail, and you could potentially have the healthcare professional do SDMQ-Doc and the patient use SDMQ9 for the same consultation, and you could compare what their estimation was of how effective the shared decision making contribution was. So moving on, there's links to some training resources which are really good. And then on again, please. Resource questions. Sian had a leaflet there about ask 3 questions. There's links to Bran, and that's a really useful mnemonic. What are the benefits? What are the risks and consequences of the option? What are the alternatives? And what happens if I do nothing new or different? And you can use Bran in just almost any situation. It's something you can use personally. I mean, I used it when I was talking to the vet about options for my cat. It's fun. It can feature in any situation. Let's move on, please. And the final thing I'd like to talk about, just to mention, is this free e-learning package that colleagues here today and Keel put together 6 interactive modules, bite-sized chunks, to really expand your knowledge and skills around shared decision making. And best of all, the last module, excuse me, the last module has some virtual patients to help you practice your skills. So it's as practical as it could be for an e-learning course. There's 2 cases. There's a statins case, and the picture at the top there is from that. And there's one about some MSK cases as well. It doesn't matter if that's not your actual kind of scope of practice. My daughter's a midwifery student. She did the statins case, and even though she didn't know the therapeutics of the statins in the same way, she certainly got a lot out of it. And that's free. You don't need to register. And being computers, of course, they don't get tired. They don't get bored. They don't get upset. You can't insult them, and you can't actually do them any harm either. So it's a great way to try out your skills. Right, I'll shut up now and move on to the real life practice of shared decision making. I think we're going to go on to Julian now. Is that right, Victoria?
We are, yeah, absolutely. Thank you so much, Andy. And I think it's so fantastic that we now have this guideline in the system with all its attendant kind of information to support people putting this into practice. It really sends a signal that this is an important thing that we expect the system to deliver against. So, Julian, I'd like to hand over to you. Julian Treadwell is a GP and a doctoral research fellow with the NIHR, and he's going to talk to us about shared decision making in general practice. Thank you, Julian.
Hello, everybody, and good afternoon. I hope you can see me and hear me okay. I'm just going to make a few comments, as the other speakers have covered all the really important main points of all of this. I've been a GP for a number of years and actually ended up making a mid-career change into academia, pursuing an interest in shared decision-making, having found over the course of a career that this is really difficult. And things have come a long way in the last 10 years, and it's really welcome to see this nice guideline come out, which I think brings together a lot of work that's been happening quietly in the background for a very long time. Just to echo a number of points that have been made, really, and the first one runs throughout all this is this idea of patients' preferences and making a preference diagnosis. And I quite like this concept of making a diagnosis of somebody's preferences. In the King's Fund report from 2012, which is called Patients' Preferences Matter, that Alf mentioned, it starts with an imaginary story of two women who have breast cancer. And one of them has a breast lump removed and has a mastectomy. And it's discovered afterwards that the lump was benign, and she had the operation because of an error in the histology lab. And she underwent this treatment for no good reason. And you can imagine how catastrophic a failure of healthcare that would be considered to be. And then it's contrasted with another woman who has a breast lump, which is a cancer. And after a consultation with, let's say, an over-enthusiastic surgeon, she has a mastectomy as well, because she thinks that's the best treatment for her and most likely to keep her safe. Afterwards, she discovers that other alternative treatments were available, and that had she been adequately informed about the options, she probably would have chosen no surgery and medical therapy. And the outcome is the same for these two women, and both of them have had an unnecessary operation. And that's a really powerful story, and it really made me think. And it's a good reminder to us all to really think hard about this. As healthcare professionals, we all have a very powerful values and beliefs that we're unconscious of and conscious of. And it's really important to actively check in all the time, and this working hard at what matters to you and what are your preferences, I think, is really important. In general practice, I sometimes find simple questions are quite an easy way to explore this. Something like, how do you feel about taking pills in general? Is quite an effective one when talking about long-term treatments, for example. Or when somebody has received a new diagnosis like diabetes or osteoporosis or something like that, having a conversation about what they understand that to mean for them, and have they heard about what harm this may do them. That's quite a good way of just getting people's perspective on where they're at as regards their healthcare. Next is the consultation model for shared decision making, and Andy outlined that, this 3-talk consultation model. And GPs will all be familiar with consultation models of other kinds that describe how consultations can run. And we know that they are all a little bit artificial, and no consultation ever runs like that. And that's true of this one as well. However, the 3-talk thing is really valuable. The first element, which is introducing the very concept of choice, so making people aware that there is a choice available, and that can be something that is a foreign concept to people. But making sure that there's an understanding somewhere early in the consultation that you're going to have a conversation about choice before moving on. You could even think about how you could embed that in your practice by making other members of the practice team aware of shared decision making. So are your chronic disease management nurses aware that there might be choices available in terms of drug treatment for cardiovascular risk, for example? And so that concept could enter the patient journey earlier, so you don't have to do it in one consultation. The next part is describing the options available to people. And this might involve talking to people about numbers and getting a patient decision aid out on the computer or on the desk in front of you. But it might actually be a highly qualitative conversation where you do get to use your clinical judgment, hopefully backed up by you as a clinician having some knowledge of the evidence around the treatment options that are available. You don't have to talk to people about numbers, and many people don't want to actually have that conversation, but do value a softer qualitative conversation with their clinicians, taking into account their values and preferences. And just a comment to reinforce what Andy said, how to handle these conversations about presenting pros and cons and treatment options to people can be quite difficult. And the 2 techniques that are in the NICE guideline of chunk and check, which is giving people information in little bite-sized pieces, then checking they've understood it before moving on to the next thing, because some of these consultations are complicated. And the teach back technique, where you basically ask people to repeat back to you as if they're explaining to somebody else what you've just told them. Those are really useful. So all of those elements can be used in any order, and they can be used over time. These sorts of decisions in primary care might happen over 6 months or a year, or you might come back to them again over a number of years. Also, we're often dealing with multiple decisions to be made in one consultation, and we don't have to do it all at the same time. We can explore this bit by bit and involve other members of the practice team to share those decisions. And understanding all of that, I think, can make the concept of shared decision making a bit less threatening. I'll just, we're short on time. I just want to finish with one point that always comes up talking to GPs, and I expect other clinicians as well, and that is medico-legal anxiety. Everybody, or many people are worried, you know, what if I don't follow a guideline? What if I have this lovely shared decision-making conversation, I do it all right, somebody chooses not to, say, take a statin, they have a heart attack a few years later, I get blamed for it. And I would say this is probably one of the biggest barrier to shared decision-making in primary care, at least. I just want to reflect things that come up already in this talk. One is the Montgomery judgment of a few years ago. The second is the GMC consent guidance of 2020, which reads like the NICE shared decision-making guideline. And the other is NICE's advice itself, which Andy talked to at the top of every guideline about exercising judgment, values and preferences, and that following guidelines aren't mandatory. So all of this stuff is there in writing to support us. However, we still may receive complaints. I think we've just got to take a bold view about that. I think I'd agree with Ashok that good shared decision-making conversations reduce the chance of you receiving a complaint. And that may be a conversation that happened before we've started broadcasting. But the way I handle this anxiety is I have as good a shared decision-making conversation as I can do. I document it just briefly in notes, perhaps with a reference to what information tool I've used to share information with, so that it's there. And then I think I've done my best. And we take clinical risks all the time in primary care and in any healthcare setting, and we risk complaint and unexpected things happening in every aspect of our practice. I don't think shared decision-making is any riskier than any other aspect of our practice. So these fears are not unfounded, but I would really hope that as time goes by, they become less of a barrier to shared decision-making. And I'll leave it there. Thank you very much, everybody.
Thank you, Julian. That was really, really insightful, and I think it's incredibly good to remind us all that actually that clinicians are coming to a consultation with their own values and beliefs and preferences, and I think that's, you know, it's really important that we acknowledge that. And the medico-legal risk, I think, is again really interesting. Over 20 years ago, when I first started working in clinical guidelines, there was lots of similar conversations about the role of guidelines and whether people would be held accountable from a medico-legal point of view. And those fears have become unfounded. And in fact, people use guidelines and probably shared decision making as defences rather than kind of reasons to complain and to attack clinicians. So I think it's really useful to be reminded of those things. So thanking all of the panelists so far. Unfortunately, Alpha's had to leave us, but perhaps we could go to the questions that have been posed in the Q&A box. Let's have a look. Perhaps the panelists could put your cameras back on so I can see you. So Laura, are there any questions that you think we should start with? No.
Unmute myself, sorry.
Sorry.
I guess it's a question, I don't want to pick this up, but how can SDM be implemented within a group of patients who are in minority groups, for example, vulnerable patients, patients who are not English, people with low levels of health, such as the homeless community, etc.? There are panelists have any experience in that area?
And I know there's quite a lot of research been done on this, hasn't there? I think in Newcastle, in Richard Thompson's team, but I don't know if the others want to pick up on this. Ashok, you've come off mute. Would you like to?
Yeah, sure. I mean, those are groups that it is certainly more challenging, and I think in general you usually need a bit more time. You need to try and see who other stakeholders are whether it's you need to make sure you have translators, you need to have maybe family members, but you have to be wary because people are not always interpreting what you're saying. So that's where that teach back really makes a difference, because you want to know that they've understood what you're trying to say. And this is about, back to the original thing I was saying about assumptions, assuming that just because I say something in what I think is lay terms relevant to that person, that they have actually understood. And I think that's why the business about chunk and check and teach back makes a real difference. But usually in these groups that people talk about, vulnerable groups, you need more time to ensure that you have really good understanding and comprehension.
Thank you. Thank you. Julian, I don't know if you want to come in, or Sian. No. And I know that there was a piece of research that came out a couple of years ago that looked at kind of doctors and patients' views of a conversation on prognosis for people with cancer, and the patients and the doctors had completely different perceptions of the patient's prognosis depending on, you know. So I think there is something about not making assumptions about the language that you use, and making sure that any tools that you use are catered to people with low levels of literacy and numeracy. I think that's really important. Laura, any other questions you want to?
Yeah, I'm gonna group them together, but they're quite interesting. So someone's asked how SDM fits in with involvement with carers, and the nice guidance in this, and following on from that, any examples in paediatrics as well. So I think that's looking at two populations, you know, carers and children, young people, how we do SDM in those populations.
I think we have to be very cautious with paediatrics that we don't assume parents can always act as proxies for children in their decision making. So I think it's a very challenging area. Sian, do you want to come in about carers? Do you want to say something about carers and involvement in shared decision making?
Only that as a committee, I think we felt it was important for the previous question of talking about certain people who are in more vulnerable circumstances. It was really important to involve their families or their carers in those consultations. And I've had experience as a volunteer where I think Ashok mentioned we used translators in terms of cancer care and consultations as well.
So it is possible to involve carers in the decision making, I guess, if the person themselves wants them to be, because that's a really critical part of it, isn't it?
This was an important part of the discussion, is that it had to be moved to a sense.
Yeah, absolutely. Andy, Julian, do you want to comment? No? Do we have any? We don't have any paediatricians. But I guess, Julian, you probably see more children than the rest of us. What would you do if a parent and child came in and you needed to make a shared decision making? You need to make a shared decision, and the child was the patient.
Yeah, I don't know. It's an interesting question. I'll think of a great answer in about half an hour. I think with carers and parents, it's just important to work out how aligned those two people's views are, as Chuck alluded to as well, and Sian. And that's the key element of that kind of consultation, I would think.
Yeah. Okay. Andy, you've come off mute. Did you want to?
Well, it was just I'm very much coming at this as not a GP, but there'll be GPs will be familiar with many health professionals will be familiar with things like the Get It case and those kind of things, and there will be stages at which I think one has to think about the child or young person's ability to understand the implications of their choices, and that's going to vary from situation to situation, but there certainly is kind of legal precedent for people to be involved in decisions about their care, make important decisions when they are kind of not an adult, as it were. But that gets quite complicated, I guess.
Yeah. Laura, we've reached 1 o'clock, but perhaps we could, if there's time for one more question, maybe.
Yeah, this is one for Julian, really. Is it important to code SDM consultation in a GP setting?
Coding, yeah, it's always an extra bit of effort, isn't it, to find out an actual code. I don't think it's an important measure from the GP's point of view at the moment, is it? It's not, you know, performance manager or anything, and I think it would be a great shame if it ever was. But clinical codes are really useful, and having later in my career had more insight into research, we can see how valuable the coding work that we do in primary care is. So I think it's a good thing to do if you can, but I would hesitate to say wag a finger and say GPs must, because there's nothing more likely to make us hate shared decision making than to make us have to enter a code when we do it.
No, we want to encourage people into this way of practice, don't we? Not to kind of enforce it. But because of time, I'm very sorry, but I'm going to have to draw this to a close. I want to take this opportunity to thank the panelists so much for their contribution this afternoon. It's been absolutely brilliant. The questions that we haven't got to, as I said at the beginning, we'll theme and we'll respond to. This will be available on NICE's YouTube channel in a couple of days' time, so we'll let you know when that happens. In the meantime, please do get in touch if you have any queries about NICE, about what we're doing around shared decision making, and please do complete the survey that you'll be directed to after this session finishes. So I'd just like to take this opportunity once again to thank my panelists and to thank everyone for attending. It's been really fantastic to have so many of you with us this afternoon. So thank you all very much indeed, and goodbye.